Good evening and welcome to the SAEM RAMS virtual meeting. I'm Dr. Andrew Starnes, president of SAEM RAMS. For those of us joining us for the first time, RAMS is a body within SAEM of over 3,000 residents and medical students that serves to give residents and medical students a stronger voice in the SAEM community by developing educational content and annual meeting programming, promoting mentorship and career development, and identifying leadership and advocacy opportunities of particular interest and importance to our junior members. Today, we're proud to bring you a presentation entitled Maintaining Momentum, Resident and Medical Student Education and Research in the Era of COVID-19. During this presentation and during our questions and answer session, you'll hear from 4 emergency medicine faculty members coming from the departments of emergency medicine at Emory University, UMass Medical School, Stanford University, and UC Davis. They'll share their expertise in education, wellness, operations, and research. During the presentation, you may submit questions for the presenters by clicking the Q&A button in your Zoom menu interface. Questions that are upvoted will be prioritized during our questions and answer session to start immediately after our presenters have concluded. To kick things off, I'd like to introduce our speakers for this evening. Dr. Michelle Lahl is an associate professor and associate residency director at Emory University. Dr. Jim Holmes is professor of emergency medicine at UC Davis. Dr. Ryan Riviera, clinical assistant professor of emergency medicine at Stanford. And Dr. Bird, chief experience officer at UMass Medical School. Welcome to you and thank you for being here. Dr. Lahl, let's go ahead and begin with you. Please begin when you're ready.
Thank you, Dr. Starnes, for the opportunity to speak with you all today. It is an honor to be here sharing our collective experiences. So as Andrew said, I have been part of graduate medical education for over 10 years and am currently an associate residency director at Emory. So I'd like to kind of take us through what our education system looked like before COVID, what we look like now, and the opportunities that we have in the future. So all of you listening who are residents now, you know this. This was the GME status quo prior to COVID. So you probably attended in-person weekly didactics. You had the limited opportunity to get III credit or the individualized interactive instruction. You probably attended journal club. You chose your residency program, probably at least in part based on the volume of patients that the department saw every day and the acuity of those patients. You had your rotations as scheduled, and you were hopefully getting yourself to at least a national meeting or maybe a regional meeting, and you were going to engage in some networking opportunities at those times. So something I think that is important for all of us to think about is all of those things are very social components. And I'm sure Dr. Bird will touch on this later when he speaks about wellness. But I think that is something that we're going to talk about a bit more, but that is important to remember, that opportunity to see your peers and your colleagues with great frequency outside of a clinical shift. So for those of you listening that are medical students, right, our undergraduate medical education colleagues, many of you who are 4th years now, hopefully you got lucky enough, you planned your MS4 rotations, you likely planned for a rotation in your home institution, and maybe 1 or 2 away rotations. Your rotations went off without a hitch, as scheduled, probably until about March, but you were able to go and visit programs you were most interested in, you were able to do second looks, you probably attended some in-person didactics while you were on rotations, you were able to take your USMLE as you had scheduled and planned, and hopefully you had the opportunity to engage in some of the emergency medicine interest group, large groups events. And as you all know, this is so important because it's an opportunity to meet and see the residents outside of their clinical environment. And we all know that there are many great training programs across the country in emergency medicine. So a large piece, and maybe the most important piece, is fit and how you feel like you can fit with that collective group. So COVID-19, I think this is our new reality. I think we've all come to recognize that this is a marathon and not a sprint. One of my colleagues in New York said to me the other day, she said, you know, you need to pace yourself. This is going to continue. So I think we need to be prepared that this will be our ongoing new reality for the foreseeable future. And while there have been many challenges, not everything is a challenge. And I think COVID-19 has actually brought some amazing opportunities for education in emergency medicine. So to start talking about challenges, I'd like to start with clinical care. So I don't know what your hospitals look like, but at mine, we've seen a loss of volume to about 60% of our normal. So 60% at a pretty big place, like where I am, is still a pretty busy ED, but it's very different than what we're used to. Many of our residents, particularly those that are about to graduate, are concerned. When the COVID-19 pandemic, when we move beyond it, will they be able to work fast enough? Will they be able to see enough patients? We've also seen a loss of bread and butter emergency medicine cases. Where have the patients gone? Not only have we seen fewer patients, but we know we've been seeing fewer STEMIs, fewer strokes, fewer surgical emergencies, including appendicitis. Where are these patients? And as you know, in education, and particularly in emergency medicine, pattern recognition and experience are critically important. So with the loss of these cases, we are worried about our trainees and the volume and number of patients they will have seen. One of my greatest concerns as an educator is tunnel vision. Is everything really COVID? It seems that in this era, COVID has jumped to the top of every differential diagnosis that we can offer in emergency medicine. And certainly when this pandemic started, most screening protocols really revolved only around travel or a known exposure. And as we have moved through this pandemic, we have seen that now almost any symptom buys you a screening for COVID, whether that's cough, chest pain, shortness of breath, myalgias, sore throat. Even now we've added diarrhea, rash. It's just about anything. And I worry that we are not adequately educating our residents on some of the more bread and butter diagnoses because everyone is so focused on COVID. The other major issue I see in our clinical departments is boarding. I work at a hospital that does not have many private rooms. We don't have that many negative pressure rooms. So where do the patients wait? They wait in our emergency departments. And some of these patients are critically ill. And we know that boarding is not safe for patients, but it's also not good for education. It's very difficult and frustrating to come into a shift and take care of somebody who's all of a sudden crashing when they've been in your emergency department for 50 hours. So let's talk about education. So I'm only going to say it once, but back in my day, when I went to medical school, we had paper notes and you had to take notes. So you had to go to class to actually receive the information. And some of the professors were willing to do an audio recording that you could make a cassette tape copy of and listen to if you had missed a lecture. So for many of the educators that you work with, we are very used to formal didactics where everybody comes and you sit and you listen together. But obviously we aren't able to do that anymore. So we now have lost some of the camaraderie that I think we all achieve with in-person didactics, but maybe we've lost some of the interaction too. I know for us, when we have our morning didactic series, it's often a time to have, as a faculty, have a one-on-one with a resident to talk about an interesting research idea, an interesting patient to follow up. And unfortunately, we are losing that in this era. We've also lost the ability to have in-person journal club. And in my institution, journal club is held at a faculty member's home and is a really lovely social experience for both the residents and the attendings and our medical students, where we can all get to know each other, casually talk about some interesting things in emergency medicine, but just share camaraderie with one another. Additionally, we've lost the opportunity for many of our simulations. Emory has a beautiful simulation center that is closed because the university is closed. We have third-year residents that are graduating here in just a few weeks that I know we're hoping to have a few more opportunities with SIM to do those critical rare procedures that nobody ever feels like they are well enough trained to perform. The other big challenge is regional and national meetings. I'm sure there are many of you listening to this that had clinical images, posters, abstracts, even didactics accepted to meetings that have now been canceled. And while being accepted in and of itself is an amazing accomplishment, there certainly comes disappointment with not being able to present your work. Additionally, recruitment is going to be a big challenge. And right now I'm going to focus on the residents and their ability to look for jobs, but don't worry, we'll be talking about residency recruitment as well. We're looking at a very different landscape. We're looking at a tighter job market. We're looking at virtual interviews, and we're looking at limited budgets. And I put this here because often many residents will go to the large national meetings and set up many in-person interviews with people from different groups and institutions. And that is a loss for our residents who are looking for jobs. Additionally, given everything that has happened, and you probably all have heard that the May oral examination from ABEM was canceled, there will be a delay in board certification. There's an entire cohort of individuals who will now be pushing the entire system back. Now that in and of itself should not be a major concern to you. When you look for a job, they want you to be board eligible or board certified. And ABEM has graciously extended everybody's board eligibility period to decrease stress in this arena. So let's talk about our medical students. So our medical students at Emory were pulled from clinical duties beginning in March, and they were abruptly pulled. There was no opportunity to finish work. There was no last shift. There was none of that. And our medical students at Emory rotate on a little bit different schedule than a traditional medical school. So our students interested in emergency medicine usually are rotating with us now, and they're not able to. And there's a lot of politics going on with the school to determine when the students can come back and when it is safe. And I know that is amazingly stressful for all of you. There will be limited or no away rotations this year for fourth year medical students. But I want to tell you that that's okay. If you talk to some of us who are a little bit older, a little bit grayer, we will tell you that when we were interested in emergency medicine, people only did one rotation. There was not this phenomenon of doing 2, 3, 4. So it's going to be okay. We will make sure it's okay. I can tell you that the Council of Emergency Medicine Residency Directors, or CORD, as well as CDEM, which is the Clerkship Directors in Emergency Medicine, have been working very hard and very collaboratively to make this as stress-free as possible, as we know this is very uncharted territory for all of you. Additionally, you suffer from the loss of in-person didactics. It's not quite the same to ask the screen a question as it is to ask somebody after they've given you a talk. You've lost your opportunities to do simulation, and you are likely looking at a virtual interview season, which is uncharted territory for all of us. But I want to shift gears. There are a lot of opportunities here, and there is room for so much growth within our specialty. So to start, I just want to start by mentioning FOMED. I'm sure all the younger people on this call are very aware of these collaborative and interactive open access medical education resources. And they have been coming out of the woodwork, and people who normally charge for their content don't and have offered discounts. And this is amazing. This is an amazingly collaborative way to share all of our information to one another and to ensure that everybody is getting the education material they need, particularly if their home institution is struggling to provide it to them. I think there are some opportunities to discuss with distance learning. I know many of my residents have felt like virtual conference is just about the greatest thing we could have ever done for them. I will say, when I monitor the chat, as I often do, we have residents who speak up in the chat to ask questions, to provide opinions that are normally afraid to do so in conference. We've definitely seen an increase in the number of interns that will speak up and say things, and it's wonderful not to have to call somebody out in a lecture hall to answer a question. I think the other thing that these virtual opportunities have offered is more time. So we have residents who traditionally come in to work a shift after conference, and that's a long day, to come and attend in-person didactics from 7:30 until 12, have a break, and work from 1 to 11 p.m. But now they're able to do this at home, and they find that time savings in commuting and not having this hour lost where they're wandering around our admin building before their shift is of great benefit to them. Virtual Journal Club, We've been able to have very engaging discussions and bring in outside speakers because we're using virtual technology. And they have found more opportunities for III. I think remote meetings maybe impact the faculty a bit more than they do the residents, but nevertheless, at least in my shop, even with the COVID traffic, which I am thankful for in Atlanta, I still have to give myself a large amount of time to drive to the hospital, find somewhere to park because our parking deck is always full, get into the meeting, get set up, attend the meeting, and then go home. So more often than not, a 1-hour meeting easily becomes a 2.5-hour adventure away from home. So these remote meetings have given us all back a little bit of time. And I think finally, the big opportunity here is around camaraderie, collegiality, and support. I'm sure you guys have seen on Twitter and on Facebook all of the subspecialists saying, "I will never give you crap when you call me for," and thanking us for what we do. And I think oftentimes we are a thankless specialty, and it is amazing to have this kind of outreach and support from our peers. So moving forward, as I said, ABEM has been working very hard to take the stress out of this. The concert exam, when you take after 10 years, has been released early so that people can take it from home. We've seen this huge increase in open access medical education content, whether that's webinars, podcasts, even material that's just available on websites. And I think we are moving to a GME culture that is truly positive around distance learning, which I know for many of you that have recently finished medical school, you maybe didn't set foot inside the school unless you had a lab or an exam. And I think the older guard has been a little bit slow to understand that this is the way things are done now. So I think this is great momentum forward. And beyond COVID-19, I encourage you all to innovate. I want you to think about what you can bring to the table when you come looking for an academic job. There will be new niches that come out of this experience. We will be looking for those who are experts in distance learning and how to optimize distance learning and ensure that our learners are getting everything that they need. We'll be looking for those with expertise in phom ed and pushing phom ed beyond where it is now. And there are novel opportunities. I'm sure you have all seen and experienced things that could be tweaked and done in a little bit different way to be more impactful. We are ready to listen. And other medical education innovations. You are the future of emergency medicine, and you are all amazingly bright. You are the education innovators. So take some time, take a deep breath, and sit down and think about what this could look like for you in your future career. Because we're ready. The educators are ready, and we're listening because we need your help. Thank you all very much. There is my contact information and my Twitter handle if you need anything, and please send questions. Now I'd like to hand it over to my colleague, Dr. Jim Holmes, who is going to talk to you all about research.
Thank you very much, Michelle. That was great. Really some very important information there. So I'll change gears a little bit and talk about kind of resident and medical student research in the current era and how COVID has impacted that and what we're going to do going forward. So if you look at prior to COVID starting back in the beginning of March, medical student research was essentially optional. Some opted to do it maybe because they have a desire to potentially get into a research career. Some do it to enhance their application for residency, but it's not something that was necessary. And there are a variety of options out there based on the particular institution that you're at, including things like research electives where you can actually get credit. And we have a fair amount of medical students at our site that will take research electives with us for credit and produce a project during that. And then when you look at the studies that medical students have typically done over the years, they tend to be retrospective or database studies, surveys, or assisting with ongoing prospective projects. And certainly COVID has impacted those types of things, and we'll talk about that a little bit more in the coming minutes. So when you look at actual medical student research, presentations at meeting is a big thing, and it's one of the ways that you can get to a regional or a national meeting. And about 15% of all abstracts presented at regional meetings are presented by medical students, and at national meetings, that's about 10%. So a fair amount of the abstracts that we see at these meetings are presented by medical students, and certainly that's desired. It gives you an opportunity to talk about what you did on your interview trail. And then if you can advance that to a manuscript, it's quite good. If we look at the resident opportunities, that's almost synonymous with the scholarly project, because residents that are doing research, that is going to count for them to satisfy their scholarly project. Same types of things with medical students, in that you have a variety of options based upon the institution that you're at, and research electives at many places are available so that you can do your, take a month, do research, produce a project, satisfy your scholarly project, and then submit that project for abstract or manuscript publication. Similarly, very same types of projects where it's retrospective, database driven, occasionally prospective, but a lot of times it's surveys of either their colleagues, faculty, patients, or even people that might be waiting in the waiting room on their family members. This is all prior to COVID-19. A little bit more, about 30% of the presentations at regional meetings are by residents. About 15% at national meetings are by residents. So if you look at that, almost half of the presentations at regional meetings are done by either medical students or residents, and about 25% at national meetings. Obviously, residents as well ultimately will go to abstract or take the abstract to manuscript for publication. We found that about a third of those that create their abstract will ultimately take it to publication. The main goal, I think, with residents, though, satisfy the scholarly project requirement. Next slide. So what's our current reality now? Well, you look, institutional travel was stopped in March at many, many sites. And what does that mean? Faculty were prevented from going places for medical meetings, medical conferences, and that started in March. That quickly followed by stay-at-home orders that states or local communities created in mid-March, towards the end of March. And then, as Michelle mentioned, medical student clinical rotations were just abruptly stopped at many locations. Sites now are restarting them. We just restarted ours here last week, but that's not the case at every place. The big issue, though, is visiting rotations have been placed on hold. For the current research reality with COVID, patient enrollment stopped at many centers. Some places like ours started COVID studies, and patient beneficial studies still were active. What do I mean by that? If the patient potentially could benefit from the intervention, that study could continue. But anything that didn't offer a patient beneficial type event had to be put on hold. So prospective observational studies that are frequently done in emergency medicine were all stopped. We're now restarting some of these other studies. So we're trying to get back to what we were doing before COVID hit in mid-March. Please note that retrospective studies are still very feasible, and because they can be performed virtually, where you're reviewing charts from outside the ED at your home, wherever you can get access to the patient's electronic medical record. So what's been the impact from a research standpoint? Spring regional and national meetings have been canceled. That's obviously why we're here on Zoom. There's certainly not a lot of optimism about fall meetings. We've trained our research coordinators for other duties. So our research coordinators, many of them are working at home, trying to clean databases, answering final queries, but we've also trained our coordinators to do callbacks in the emergency department. So our research coordinators for the past 6 weeks have been calling patients back with their COVID results. There has been increased interest in research elective rotations, but not from visiting students. It's been from our students have expressed increased interest because they're concerned that they won't be able to do away rotations. And I'm sure you've all seen this website and probably looked at it frequently and keep hitting F5 hoping things would change. But this is the website for visiting student learning opportunities. And it has put everything on hold and will not reopen until May 19th. After May 19th, the opportunity is potentially there for visiting rotations, but realize it is going to be a very situational site-by-site opportunity. We've noted that submissions to academic emergency medicine have increased. There's some obvious increase in that due to COVID manuscripts being submitted. And then some projects that kind of have been put on the burner have now been started, because some of our faculty now have a little bit of extra time on their hands. So some of the things that I've had scheduled to do got canceled. So I actually just put together an IRB for a retrospective study for one of our residents to do here in the next few weeks. So what's the future bring with research? And now that COVID has impacted our lives like it has, retrospective and database studies still exist. Surveys can still be done. And think about the impact of COVID on patients, staff, and providers. Think about surveying what the impact is on the patients, staff, or providers at your facility and how COVID has impacted their lives. Probably the most important things, and I'll end with these final 2 points, is please discuss with your advisors about local opportunities. The interactions that you normally have with your faculty, between faculty and students and faculty with residents, have certainly been decreased in the current COVID environment because there's just not, people aren't meeting in the hallways, people aren't meeting in their offices like they used to. So you have to be very proactive to discuss with your advisors about local research opportunities if you're interested. And then probably most important, be prepared. Identify away research electives if there's no opportunities for rotating in the clinical environment at a site you might want to go. And what I mean by that is if you want to do your residency, if you're a medical student, you want to do your residency at site A, you might think about contacting site A to see if there's an opportunity for a research elective that can be done virtually and that you can interact with the faculty at that site so that they can learn things about you and you can learn about them to determine if that's where you want to go. So thank you very much. I'm happy to answer any questions that you have and will be around for the rest of this talk. I will now turn it over to Dr. Riviera.
All right, thanks so much, Dr. Holmes and Dr. Lal, for your presentations. So we're going to, again, change gears a little bit here and talk about the operational impact of COVID on our emergency department. So I'm Assistant Medical Director of the Emergency Department here at Stanford, and more specifically, I oversee a lot of our scheduling and a lot of our operations. And so I'll talk a bit about what happened in our ED, which, obviously we're probably a medium to large sized academic ED. It's not necessarily going to be representative of what happened in a lot of hospitals across the country. But I think actually the course that we followed actually was relatively typical in terms of the volume, as we'll discuss as we go forward. So hopefully it gives you a picture of kind of what's happening. And then we'll talk a bit about specifically its impact on medical students and residents, and then what we can expect going forward, what lessons I think we'll take into the future from this, the developments during COVID. So we can go to the next slide here. This just gives you kind of some baseline information about our emergency department. So actually what I'm showing you here is the stats of our 300 PED. This is now our pediatric ED, and then the 500 PED, that's our adult emergency department that actually very fortunately we moved into just in the fall. So we drastically expanded our footprint, our number of beds, and importantly, our number of private rooms. So we had that in our back pockets going into COVID. And then this is just a floor plan showing you it's actually a relatively large ED. We operate in a pod system, which is relatively popular these days, and probably many of you, when you've done rotations, and shadowing and EDs. You've been in EDs that follow a bit of a pod-based system. We can go to the next slide here and we'll see the volume graph that is going to serve as kind of a guide for us as we go through chronologically how our ED adapted from an operations perspective as COVID progressed. And so this shows us starting here in March. I'll just orient you to some of these lines here. Blue is our overall volume. Red is the number of patients that were tested for COVID. Green is our admitted patients. Yellow is ICU. Orange is our admits. And we'll keep that consistent as we go through. So you can see kind of in early March, these were essentially our normal pre-COVID volumes. And this is just showing our adult ED, actually. Our PEDS ED is excluded from this data. So, 152, 200, 166, 193, this is a moderate to high volume kind of ED experience. Many of you probably work in EDs similar to this. And I guess one other thing that's worth noting that probably differentiates us a little bit from other emergency departments is that we did have an in-home test. So we had access to COVID testing that had been developed by Stanford. And so even in these early stages, early March, our testing capability wasn't necessarily very volume limited. We were able to test almost anybody that we felt it was appropriate to test, even from the early stages, which I know is not the case for a lot of other institutions. So that means that the tested for COVID number here relatively tracks to the number of patients who we suspected could have COVID, PUIs based on CDC guidelines. So you can see there's a huge upswing here around March 11th or 12th. And so as an operational team, this was a change in volume and a change in the type of patients that we were seeing in our emergency department that was happening with a speed that we hadn't really ever seen before. And so we knew we had to move fast, and we had to change the way that we were doing things to adapt to this new patient breakdown that we were seeing. So you can go to the next slide here and see that one of the first things that we did is we changed our shift structure around. We were trying to give ourselves a APP. In addition to the one that's shown here, we had APPs that we then dispersed throughout the emergency department to help with this increasing volume. We had a resource doctor who we moved out to take care of our increased volume of COVID testing patients. We'll go to the next slide. You can see that we took our garage and turned it into a low acuity COVID testing and treatment space. We were able to roll this out pretty quickly over the course of just a few days. And this is, if you're in disaster preparedness for hospitals, utilizing a model like this is something that has often been theorized and written about. And most institutions don't have very many opportunities to implement it. But we, unshelved our disaster plan and turned our garage into a COVID testing area. And so, as you can see, unfortunately, we don't have time to delve into the details of how we operationalize each element of this. But we had a process whereby patients who are concerned they might have COVID were screened before they even got out of their cars. And then they drove into designated areas in the parking lot where, again, without getting out of their cars, they were approached by a nurse in PPE who did the swab. And this is a model that a lot of other institutions, followed as COVID progressed across the country in various forms. In addition to the car testing, we had a few different treatment areas. You can see there in the upper right, where for patients who didn't have significant vital sign abnormalities, we were able to treat them in the garage via a nurse clad in PPE and a physician joining via telemedicine. You can go to the next slide here and see just a representation of kind of what that process was like. And then going one slide further, we'll see we also had to roll out very quickly some telemedicine processes, and the pressures around this were both because of the increased volume of isolation patients that we needed to assess, and also because of the PPE burn rate that was becoming very high. So in these early stages, as you all know, I think the general public even was aware that PPE was in very short supply. And when we were seeing, 120, 130 patients a day who needed COVID testing, our own supply was getting very low. And so telemedicine was seen as a solution for managing the volume efficiently and managing our PPE stores. And so we had a pretty extensive telemedicine program that we spun up literally over the course of a week. So we would have a nurse at the front of the ED who would meet a patient, would screen them for ILI symptoms. If they screened positive, then they would initiate a teleregistration process whereby our registration team would zoom in through an iPad, finish the registration process. If that patient was low acuity, they were directed to the garage where they were seen, as I mentioned, by a physician via telemedicine. We had a nurse who was pulling a cart around within that garage. And then if they had more severe symptoms and they were brought outside the ED through a side entrance into our isolation rooms. And in each of those rooms we had, you can go to the next slide here, an iPad that was outfitted with Zoom, and our physicians were able to interact with the patients through that iPad. And this was, again, something that we rolled out over the course of probably a week. And from our estimates, probably decreased on average our PUI-related PPE utilization by at least 50% and probably more. We're still working on calculating that out. If we go to the next slide here, just in terms of talking about other things we had to do in regards to this rapidly increasing volume, we had to recruit huge backup call, because if we go to the next slide, we went from having about one call out a week to 1.6 a day. So sometimes 2, sometimes 3, sometimes 4. Most of those call outs were not necessarily physicians becoming ill with COVID themselves, though we did have that, of course. But more often it was testing. And once you get tested, you got to quarantine for 72 hours before that test comes back. We had also providers who were stuck in various locations because of travel restrictions. And so just in order to keep the ED staffed, we had to recruit pretty substantial backup call. Going to the next one here, of course, unfortunately, as many of you experienced, we were then also not allowed to have medical students come into the ED. And we had to think hard about even which residents and other trainees we allowed into the space. We had to think hard about our own providers, some of whom were at relatively high risk. This stock photo that I obviously didn't pay for represents the smiling faces of our high-risk providers and their flexibility as we move them around to try to find a safe place for them to be able to continue to practice in the COVID era. So we carved out certain portions of our ED and made them COVID-free zones as much as possible. We developed pretty strict triage practices to try to reduce the number of false negatives that got directed to their location. And so we tried to provide a way for them to continue to be able to practice and contribute without putting themselves at risk. And then, of course, we created telemedicine shifts, as I mentioned earlier, that were safe spaces for our docs, and then later also some of our residents who were high-risk providers. You know, another thing that we had to grapple with as we went forward was, you know, in an academic institution where you have residents, you have attendings, we have, you know, nurses and scribes and all kinds of people who typically interact with the patient. How do we decide who's the one who gowns up and puts on the PPE and actually puts themselves at risk and goes in the room, especially when telemedicine is available and we have the ability for most of those who are working with a particular patient to interact with them virtually rather than in person. And so this was, I don't know that there's a perfect answer for this, but this was just something we had to grapple with in those early days. You know, how do we share the load of risk amongst our providers and, you know, give our trainees still access to patients and the ability to go in and talk to patients and experience what it's like to have to, you know, PPE up and take care of, you know, these patients in infectious disease crisis without putting them at more risk than we need to. So then let's go forward here a little bit. This is now that 249 is that spike that you saw in the earlier graph, and we're going to follow along over the next few days what ended up happening. If you go again here forward, this is where the shelter-in-place orders went into place in the San Francisco Bay Area on March 19th. You can see immediately we had a tremendous drop in volume. And that was mostly our non-COVID volume that disappeared. And so very quickly, this was felt throughout the department. And it was just, you can go through these animations here of all these doctors falling asleep on shift, trying to figure out what are we going to do with all this excess capacity when they don't have patients to treat. So we ended up cutting zones here. We cut our fast track zone, which is our low acuity zone, because we saw that was some of the volume that was falling the fastest. And then as time went on, it ended up not just being a little fluke, but in fact, the volume stayed low for quite some time. This was our peds volume at the same time was dropping even more precipitously than our adult volume. And so on the peds side, they were also having to cut a lot of shifts. Yep. And we cut our walk-in clinic, which is kind of an urgent care equivalent as well, just because the volume was not there and the demand was not there. So going forward even more, this ended up being a pretty persistent pattern. And, what we were doing at that time was restructuring again to try to, reduce the excess capacity on shift. And then we were, even with that restructured shift schedule, ended up cutting even more shifts as we had docs there seeing 3-4 patients in an entire shift. So we ended up having to spend a lot of time actually trying to model out and predict what our volume was going to be. We didn't say, okay, for the next 3-4 weeks, we're going to have to cut all these shifts. So you're off the schedule, go find something else to do, because in the back of our minds, we were always worried that the wave was going to come, right? Because we were seeing it hit New York at this time. We were seeing it hit Michigan. We were seeing it hit New Orleans, and we didn't know if we were going to be next. And so that level of uncertainty, I think, very much affected how we dealt with this now low volume crisis. We were cutting shifts on a 2 or 3 day basis and not a week basis, because we always wanted to be prepared if the wave came. But at least in our location, the wave did not come. And over a long period of time, we saw persistent low volumes. But we did start to see some patterns. You can go through these little animations here too, where you can see the red bars are Mondays, the blue bars are Tuesdays, the yellow bars are Fridays. And this is not news to anybody who's worked in ED operations, that there's a day of the week variation. But at least in the early days of COVID, it wasn't sure if we weren't sure if this was going to persist, but it did, in fact. And so we restructured again to adapt our shift schedule to the days of the week, so that we could provide our docs with a little bit more predictability, and still not, and still keep our staffing right-sized to the need in the department. Overall, so far in RED, at least, we've canceled about 400 attending shifts, which very often correlates to at least 1 or 2 resident shifts as well. And they're kind of right there with us in terms of the staffing need. And this actually has ended up being a little bit beneficial, because as the volume has remained low, the next crisis on the horizon has been the financial crisis. That is perhaps affecting emergency departments less than it is affecting a lot of other parts of the healthcare system, but is still, I think, really significant. So just as a very high level background, hospitals generally run operating margins somewhere around 3%, right? Which means that the revenue they take in only exceeds their cost by 3 or sometimes 4%. And a lot of that comes from surgical procedures, and a lot of it comes from private pay insurance, right? That's what buoys up the finances of most hospitals. And I think COVID has really had hospitals taking a hit on both fronts. One of the first things that we did was shut down all non-emergent procedures, right? And so that faucet of revenue was turned off. And then while the data is still coming in, it seems like probably the payer mix for most hospitals was less favorable during the COVID era, which means that a lot more of the patients who are coming in are patients either who are uninsured or who had Medicaid, which a lot of hospitals lose money on. And so, it often seems distasteful, I think, to think about the finances of a hospital or an ED when we're dealing with a public health crisis. But there are very real downstream effects when hospitals are losing millions and millions of dollars a day, which it has been the case, I think, for many hospitals across the country. For us, the staff cutting that we've done, the shift cutting that we've done, is something that I think has helped a bit on that front. But for both operational and financial reasons, there's probably reasons that that's going to continue for some time. So then, what we're now to the present day, I think the risk of a wave of COVID, at least, in the next couple months, is pretty low for us and probably for most hospitals around the country. So what is going to be the new reality? And let's just go through a few slides here. I think for one, financial challenges are going to be real for the whole rest of the calendar year, at least, and probably even going forward. I don't think that volumes are going to come right back. And I think there are some probably who hope that once economies reopen, everyone is just going to come rushing back to the emergency department. But I think The general public is probably going to be reticent to use the ED as liberally as they used to for quite some time, as long as COVID is in the public eye. I think also the development of some of the outpatient, the new outpatient telemedicine capabilities is probably going to keep a lot of those lower acuity patients away from the ED for quite some time too. And so internally, I think we're projecting that our volume may not come back to where it was going to be before the end of the calendar year. So for some of you students and residents who are working at training sites that are probably a little bit tighter from a financial perspective, may not have all those opportunities available. I think especially for secondary or tertiary sites that maybe aren't directly associated with an academic center, for them, training is something that they might have less room to afford. And I think also just in the way that we do education and training going forward, I think budgets are going to be tight. And so thinking about how, what opportunities are available for trainees is going to be a little bit more budget limited probably than it was previously. I think that we are going to see improvements in COVID testing, and I think that is probably going to provide us an opportunity to start letting trainees be more engaged in clinical care as we're able to carve out more zones as COVID-free zones if we have, rapid testing available. And so I think that's hopefully going to be a positive development. They'll make it easier for us to get medical students and others in. And then I think telemedicine is going to become a much bigger part, and remote monitoring is what this represents, a much bigger part of clinical practice, even in emergency medicine, where I think it's historically not necessarily been a strong focus, but I think a lot of the telemedicine practices that we've had in our ED are going to persist. And in fact, we're already finding new ways to use this technology that's been installed. It came in as a result of COVID, but now we're using it to do remote research intakes. We're taking those butterfly portable ultrasounds and bringing those into the ED. So now we have ultrasounds at every bedside. And so some of this technology innovation around telemedicine, I think, is something that's going to persist. And probably for those who are residents in emergency medicine, it's going to be something you're going to have to be more facile with in the years ahead. And then I think from a scheduling perspective, we're going to see that people are going to be a little bit less liberal, a little bit more tight. And I think, like I said, for both operational and financial reasons, I think we're going to be a little bit more careful about how we staff our ED, and I think a lot of others will be as well. So, and beyond that, what's coming? I mean, I think there's still just a tremendous amount of uncertainty around operations. One of the, I think, really fabulous things that we've seen in hospital operations in the last few weeks is just how people have come together to innovate and to move things so rapidly. Hospital administration operations is often mired by a large amount of bureaucracy, and which is natural. It's there often for the protection of our patients, but projects can take 9 months, 12 months, 24 months, and 50 meetings to accomplish. And I think because of the urgency around COVID, we did things that would have taken a year in a few weeks. And I think hopefully the way that hospitals across the country have innovated around operations in this crisis will help us realize that we can be innovative, we can move quickly, we can respond quickly, and hopefully we take that innovative mentality into the future. So happy to answer questions once we get to the end here, but now I will turn the time over to our last presenter, Dr. Bird.
Thank you very much, Dr. Starnes. Thank you for the opportunity to speak with everyone here today. I'm Steve Bird. Just a little background, I was a program director. I'm in recovery for nearly 9 years, and for the last 7 months, I've been the Chief Experience Officer, which is the UMass term for Chief Wellness Officer. So I'm going to focus on resident medical student wellness. When you all were thinking of applying to medical school, and when you were applying and interviewing, you probably thought of this. This is The Doctor by Sir Luke Fildes from 1891, Victorian era physician who's called to a person's home to look at their child. What you probably don't notice at first blush is that the child isn't even on a bed. The child is stretched across a couple of chairs. In the background is a distraught mother and a worried father, and then the hero physician who is there in the middle of the night trying to figure out what's wrong with the child and what he can do for the child. And this is what we have wanted, this is what we aspire to. And then you start medical school, and this is what you got. This is a representation of health care in the United States. Numerous agencies that don't work well together, bureaucracy everywhere, overhead costs everywhere, and hospitals are fighting for a 3% margin amongst all of this. Next slide. Many of you are probably familiar with this study or similars. This looks at the change in burnout from 2013, which is the dark blue by specialty, and 2017, which is the light blue. And not only does emergency medicine have the ignominy of being the highest burnt out specialty in this study, but importantly, every single specialty experienced an increase in burnout from 2013 to 2017. And importantly, in the US general worker population, this was not seen. So perhaps it's not unique to medicine. It is not everywhere in the US economy, and it affects all of medicine, maybe not equally, but it affects them all. Now, interestingly, when medical students show up on campus, day one, first year of medical school, they are the healthiest, least burned out, least depressed members of our society, the most highly functional members of our society with the highest quality of life when taken against matched peers. But what happens after less than 3 years? Next slide. After less than 3 years, medical students look just like residents with regards to burnout, depression, and quality of life when compared to matched peers. So we take the most highly functional, successful, brightest people in our society, and we turn them into burnt out people within this confusing healthcare structure, and we do that in less than 3 years. Next slide. Fortunately, SAEM has been working at a national level through the National Academy of Medicine. And part of that work that's been going on for about 2.5 years was creating a conceptual model of burnout. This is one of the conceptual models. I would tell you there was a lot of discussion about what goes in the middle. Is it patient well-being? Is it the physician or clinician well-being, or is it both? This was the model that we landed on. And you notice that there are 7 domains on the outside that affect burnout. And what I'll call your attention to is the personal factors are in blue and the institutional system factors are in yellow. So in this model of burnout, the overwhelming majority of the drivers of burnout occur at a system level. Yet what we have largely done is focus on individual factors in trying to mitigate the effects of burnout. Next slide. So what I want to do is change the narrative a little bit. We use the word burnout, go back. We use the word burnout and wellness, but keep in mind that just because you're not burnt out does not mean you're well. So the goal shouldn't be eliminating or mitigating burnout. Really, the goal should be focusing on being well. Those are different things. Next slide. So the other panelists, Dr. Rivera, Dr. Law, Dr. Holmes did a good job of kind of setting the stage for what's going on. But with regards to resident and medical student wellness, where we currently are seems very 1982. So really the only systematic way currently that burnout or wellness is measured, for residents at least, is on the ACGME resident survey, which should be coming out, or the results should be coming out soon. And that was, I believe, 6 questions, not really validated. They took what they thought were good questions and created them. If you've seen the report for this, up until just this year, they did not even give you an idea of where you are with regard to benchmarks. So not a real ideal way of measuring wellness. There is no, that I can figure out, a kind of system-wide or nationwide way of measuring wellness amongst medical students. Our current state also involves lots of distancing, not only physical distancing, but social distancing. So not so much for medical students, but residents, right, are your distance from your family. Some people have become pariahs, not able to spend time with their family. Your distance from your colleagues, as Dr. Lal mentioned, you have distance learning. You don't get to spend any other time with your colleagues other than when you're at work, and all you see people with their eyes. So that's really caused a bit of angst. And your distance from patients and their families. When you have to put on PPE to evaluate a patient, right, you're not going to go in to the room as often as you would if you didn't have to don PPE, not only because it's difficult to do at times, but the concerns about a supply of PPE. And you're distant from the families. And importantly, the patients are distanced from their families, which really has caused some moral distress for people. I have a number of times helped navigate the conversation with a patient and their family via telephone or FaceTime when we're making the patient comfort measures only, CMO. Even CMO patients aren't allowed to have family members. And so that is really a distressing, distressing situation for everyone, physicians, nurses, everyone. And it's all over in the hospital as well. It's not just the emergency department. So one of the other issues that has come up, and I'm sure at the institutions that the other speakers have talked about, and certainly is ours, is there's a redeployment. Not so for medical students, although I'll talk about that in just a minute, but some residents are redeployed. Some fellows are redeployed. So for instance, at UMass, we have some rheumatology fellows that are doing night call in the ICU. They haven't done that in a while. And other residents, surgical residents, are largely redeployed to ICUs as well. So that is putting people in a situation that they are no longer or less familiar with than their typical clinical duties. The other thing, as a parent of an 18-year-old who's about to graduate from high school on Sunday, there's loss of milestones. So medical students have lost your graduations largely. Residents who are finishing have lost their graduation. If for our residents do a rotation in Hawaii's been canceled. So residents aren't getting that quasi-elective rotation in Hawaii. So that has clearly caused angst and some distress in people by loss of milestones, both professionally as well as personally. Next. Well, this is interesting. This is hot off the press. I got this data, I believe, on Monday. So at UMass, every 2 years, we do a physician engagement survey. And these are our results. The survey took place at the beginning of the COVID pandemic. So I think it was March 15th to April 7th, this was open. And I just grabbed a few of the questions. The score in the 2020 column is our score this year. And then on the far right column in green, those are just 5 questions that I thought had a little bit to do with kind of working together. We saw a statistically significant increase in many domains of our engagement survey. So kind of paradoxically, or counterintuitively perhaps, this pandemic, which has wreaked economic havoc across the country, including hospitals. Dr. Rivera mentioned that UMass, we are potentially going to lose $240 million this year. So despite that, potential layoffs, change in schedule, your schedule's getting changed every couple of days. Despite all of that, our physicians, and our resident data, are actually thriving, which is a bit counterintuitive, but that is commonly seen. Next slide. So I'm going to go through a few slides about some possible solutions, some things that we've done at UMass that my office, the CXO office, has instituted. And one is a peer support. So peer support is typically offered, not every place has it, but it's usually done if there's a poor patient outcome or lawsuit. And the claims office from an institution will say, oh, Dr. X there's a lawsuit. Let's send someone from our peer support who's trained in how to do that send them to reach out to Dr. X and see if Dr. X needs a bit of support. So that's how peer support's typically done. And that's what I'm calling preemptive outreach, because oftentimes people won't, on their own volition, seek help. Well, we can't really do that in person now because of COVID-19. So what we have done is institute virtual peer support drop-ins twice a day. So 8 a.m. and 8 p.m., as well as noon on Saturday and Sunday. We have 28 trained peer supporters. We have a Zoom meeting that it's free. Anyone can drop in, residents, nurses, techs, physicians, anyone can drop in at all. It's underutilized, I would say, but it's there. And every other day in our messaging, we say, this is available, here's how you do it. The other thing that we've done is, which isn't peer support, but we have identified roughly 260 docs who are what we're calling frontline. So they are actually taking care of these patients in the hospital. So keep in mind, many of you may not know that some physicians haven't worked at all in 8 weeks. So we are identified all of those physicians, including residents, and then hospital leadership. So the president, the chief medical officer, I have done it, as well as a few others, sent out individualized text messages to these people, these docs who have been seeing patients on the front line, just saying, hey, we really appreciate everything you're doing. I know this is stressful. If you want to talk at any time, here's my cell phone number. Here's Steve Bird, the Chief Experiences Officer's cell phone. Here's how you reach him via email. So that was really well received. Probably about 30% of people replied, said, hey, I really appreciate you checking in on me, but I'm okay. And of those roughly 260, only one person has reached out to my office for something more than that. After we did this and it was so successful, now GME has done this for every resident, whether they're redeployed or whether they're even working at all. So for instance, psychiatry residents have largely not been working, but all the residency directors have done the same thing, reaching out proactively. Next slide. One thing we have noticed, and in the realm of wellness is no different than others, is that communications is key. There's an adage that you should say or communicate something 3 times more frequently than you think you need to. And this is no different, although there's certainly a bit of COVID-19 email fatigue. But what we did is we've done 2 things. One, our CEO wrote a letter to all employees. It was basically saying, thank you. We know this is challenging. We appreciate all you do, as well as listing some access to support. For instance, how to reach our employee assistance program, how to reach an emergency fund that we have set up for staff, how to get better sleep, et cetera, which was well received. And then on Friday, the CEO, president, chief medical officer, chief physician executive, and I, along with the dean and the chancellor, wrote a letter to all residents who have been redeployed. So for instance, those rheumatology fellows that are now working in the ICU, so redeployed docs, just saying thank you for all that you're doing. We know this is unusual circumstances and we appreciate what you do. This, I believe, is where most gains can be made. So this is a study that was published in August from the Mayo Clinic, where they randomized docs, they had 88 doctors, they randomized them to receive 3.5 hours of wellness coaching or nothing, and followed them out for 9 months, looking at various quality of life, burnout, wellness measures. And in virtually every domain they checked, the docs who received wellness coaching were statistically improved or better than those who did not. So what we are doing, I'll tell you what we're doing at UMass. So we are training a cohort of 7 wellness coaches, including me, and we will become certified wellness coaches, and we are offering free wellness coaching to every single medical student, resident, fellow, and faculty member. Nationally interesting, there is a company called Well Coaches, wellcoaches.com. I have no conflict of interest at all with them. But if you go on their website, they are actually offering free wellness coaching to any healthcare provider right now. I don't know the details of it. It's probably not 10 hours, but it may be one or more. Wellcoaches.com. So I think this is going to be critically important because it's not just for now, right? As Dr. Lal said, this is not a sprint, this is a marathon. And the issues that are developed with regards to health, wellness, and burnout due to COVID are not going away. They may decrease a bit, but it's here to stay for a while. Next. The other interesting thing is, now I largely was guilty of saying that we're not going to resilience our way out of this problem. If you remember back to the conceptual model of burnout, only 2 of the 7 domains were really individual. But that's not exactly true. So pictured here is General and Dr. Rhonda Cornum in the upper right. She was in the first Gulf War, she was a Army flight surgeon. She was on a Black Hawk medevac mission. Her helicopter was shot down. Everyone was killed. She had 2 long bone fractures, and she was an Iraqi POW. She became a urologist. She rose to the rank of brigadier general, and she created the Army's Comprehensive Soldier Fitness Program, which is the military's resilience program. And they have amazing data about the benefits of resilience training within the military. I am not saying that medical school or residency should be like being a POW or anything like that. But I think it is informative that resilience training works. Next slide. So what does the future hopefully look like? Well, I hope that hospital and schools will make a priority of wellness. The first academic medical center's chief wellness officer was at Stanford, which was November of 2017. So it's been about 2.5 years since the first, and there are now roughly 15 chief wellness officers across the country at academic medical centers. And those are increasing every month or 2. And it costs money, right? So the hospital and the school, it's a partnership here, need to recognize that this is critically important and fund it. And they have a reason to do that, because we know that physicians that are well work more hours, they work longer, they take better care of their patients, they have less lawsuits, patients are more compliant with medication treatment plans, et cetera. So it is it's benefit to society to have well physicians. But what also is that these wellness plans need to be comprehensive. Unfortunately, what you've heard of furloughs and layoffs are coming in healthcare. There's no doubt about it. One thing I'm personally not worried about my job, but I do worry that institutions that have recently instituted this will see it as just another area where perhaps they can cut some expenses. But I would submit that we need wellness officers and comprehensive wellness plans more now than we ever have, and that needs to continue. So these wellness plans should not be one-offs, right? So what I mean by that is, COVID is an issue now, let's do a wellness survey and let's get the results back in 3 months and come up with a plan. That's not comprehensive. And we need to define efficacy of interventions. So that is, we need to study the efficacy of interventions and not via the ACGME resident survey. 6 questions is not going to do it. And this, again, takes funding and time, but that's why the schools and the hospitals need to work together to get it done. Next slide. This is my last slide. I want to offer or show you, so this is what we have done. And we did this over the course of 3 days. We were able to put this together. So this is a kind of comprehensive resources that are available to medical students, residents, and faculty. And we've placed them, color-coded them in different domains. We have COVID resources at the bottom. These are all live hyperlinks. And so we have disseminated this in digital and print format to everyone so that they recognize that our office is there. It's got my cell phone on it. Every single email I send has my cell phone on it, so that people recognize that we care about their wellness and we want them to be well. Other institutions have done similar things to this. And again, this comes because communication is difficult, right? If I were to ask 10 of you, you are having an issue or a friend is having an issue with something, how would you access support for them, right? If I asked 10 of you, I'd probably get 11 different answers because these are not often utilized and people don't know how to reach resources. So putting them in a place like this will be very beneficial. Thank you very much for your time. I'm happy to take questions as well as the other panelists.
Thank you, Dr. Bird, and thank you again to all of our speakers for this timely and thoughtful presentation. In a few moments, we'll answer questions from the audience. As a reminder, for those who are attending the live session, please send your questions in via the Q&A pop-up window by clicking the Q&A button in your Zoom menu interface. And we'll try to get to as many questions as possible in our remaining time. While those questions are coming in, we'll go ahead and lead off, and I'd like to ask Dr. Lal, you kind of touched on this, but could you dive a little bit deeper with low patient volumes? How do you expect that we'll make up for missed education opportunities during COVID-19?
Yeah, so I think this is something that as program leaders across the country, we are working on trying to figure out the best answer to that question. We haven't had a pandemic in quite some time, but after the H1N flu that struck in the late winter 2019 or 2009, excuse me, ED volumes didn't return to normal until almost 18 months after the peak of that pandemic. So again, this is a marathon. I think what we are looking at in my institution, certainly once the simulation labs are back open, we're planning to do more simulation-based education. We've been doing some low fidelity sim that we were able to do kind of internally within the department while people are on shift or not on shift. We've really put out new guidelines to all of our faculty about bedside education and really trying to make the most of every single patient encounter because I think it will be critically important really to learn the most from every patient that our residents and trainees are seeing during this time. I do think that there's no absolute number of patients that are enough, which I know is where I think some of the angst comes from. But I think in all of our academic emergency departments across the country, even with volume lower than what is normal, the patient encounters are still there and the resident experiences are still there.
Thanks. I think that's good advice. And just kind of a follow-up question for that. We talk a lot about what institutions are doing, but you as someone that works with residents, what would you say a resident's and a medical student's perspective should be about trying to make the very most of the opportunities that they do have?
So I think, typically in my emergency department, we're so busy that sometimes we don't get to spend as much time talking through a patient as I would like, or there's maybe not enough time for the learner to go back and look something up and come back, sort of that interrupted presentation. And I think what I am trying to do, I always ask at the beginning of the shift, what are 3 things that you want to learn today? And depending on the level of learner, I get a variety of answers. And then I also start at the beginning of the shift saying, I expect you to have a teaching point ready at rounds. That's normative. When we shift change, we have a teaching point from the off-going team. So let's make it a really good one this time. Let's not talk about some of the standard things we sort of talk about. Let's not talk about sepsis today. Why don't we find something a little bit more obscure, something you're hoping you're going to get to see, but you might not, or something you're afraid of seeing when you leave. And let's break it down step by step and really go through it together. And usually, when we have shift change, the teams are all changing. So it's a pretty big group. So it usually engages a great discussion from a variety of viewpoints. So I think it's really taking the time to do those things well right now is critically important.
Yeah, those are great thoughts. Thank you. Well, let's move to we've had a couple of questions, which I think are great questions, and we'll target you, Dr. Bird. I know, I hate to bring up, I know that you're in recovery, but as a former program director, I know that you're in tune with this. Could you address some of the things that, in particular, medical students and international medical graduates, what can they do now to try and navigate for a successful match, since we've really turned the process upside down, specifically with limited opportunity to do away rotations?
Yeah, it's a really great question. What I'm about to say are my opinions only. As Dr. Lal said, in the past, medical students applying to residency only did one, often their home institution, maybe in a way, and the 3 to 4 rotation opportunities just weren't there. So fortunately, I think it could be potentially tougher. But if most international medical grads, certainly from the Caribbean, have an institution in the US where they do their clinical rotations, right? So they will still have that opportunity, or they should still have that opportunity to do a rotation at their home institution. It may be more difficult to get a second rotation, but that doesn't mean that, so what else could you do? Well, it may be, as Dr. Holmes said, that you may be able to do your home EM rotation as well as a virtual research rotation. Or perhaps you can do a tox rotation where you're not seeing patients at the bedside. So maybe it's based at a poison center. I think things like ultrasound are probably going to be a bit more difficult. So, I also say that I don't think that students should abandon the idea of doing a second rotation, an away rotation. I think they need to try. It also may be that just gets delayed. My understanding, and Dr. Law probably knows, that ARIS is going to open October 15th or something like that. So, right, so that's been moved up, about 2 months or 10 weeks. So it may be that you do a rotation a bit later in the year. I think for so long, there's been an arms race in the applications. It's gone earlier. Well, this is a little bit of a Control-Alt-Delete, I think, to the application process.
Yeah, and just to echo what Dr. Bird was saying, I know that the clerkship directors and the program directors have been working very hard to identify orphaned schools, meaning that your medical school does not have an emergency medicine residency program, and really trying to ensure that any program that does have capacity beyond their own students can be a home for these students as a first priority. So everybody's working really hard to make sure that the playing field is level and that everyone will have the opportunity to do a rotation.
We have a question from Joanne that follows up on this, and I think it's a good question. She says the home institutions are not necessarily an academic, which may make the SLO less valuable. How do you expect we're going to navigate getting different letters from a variety of different departments, some of which may not be emergency medicine, if they just simply don't have the opportunity to rotate there?
Yeah, so again, there's collaboration looking at designing a new letter form. So it wouldn't be the traditional SLO that an academic department would normally write at the end of your rotation. It would be for those departments that are not academic, or even for rotations that are not in emergency medicine, for an internal medicine sub-I. And we are looking at it to design a new form that those evaluators can use to really give a great assessment of your performance that would mirror a SLO, but is not quite the same. And I think all readers of these letters, as somebody who's read thousands of these letters of recommendations over the years, we will be looking at these letters carefully. We understand the circumstances. And I think certainly a glowing letter from a non-academic emergency medicine physician in a busy community ED is going to have value.
Great. And I would just also add to this that we as a board for RAMS are really attuned and have had a lot of questions from students and residents just along these lines, and we'll continue to develop materials and continue to put products out through this year to try and address some of these needs. So continue to stay posted and follow all the things that we're doing. The next question we have from Caroline. She says, I would direct this one first to Dr. Rivera, because I think you've had to make a lot of decisions about how to juggle staffing and prioritize who is there on the front lines. She says, how do you continue to encourage residents and assure them that their work is important when hospitals are cutting pay and staff from the front lines, sending the messages that the work may not be valued?
Yeah, so that's a tough question. I'd say it's not just residents really who might feel that way, but you know, attendings and nurses and everybody, right? It doesn't feel good when you're putting yourself at risk and you're taking a 20% pay cut, or you know, getting forced PTO. Now, I'd say one thing to keep in mind first, and you know, and this is maybe not a popular position to take, you know, defending hospital administrators, but I think it's maybe a little more reasonable to be kind of take a cynical view on administration when you're talking about a time when everyone is flush with cash and, well, you know, they're not willing to invest in education. I would say that is not really what we're looking at. These are, from a financial perspective, very dark times, and I think for some hospitals, it really is, it's a very real choice between, you know, doing everything they want to do and, you know, just keeping the lights on and being able to continue to treat patients. I mean, complete bankruptcy is not necessarily off the table for everybody as these months are going forward. So I hope that, you know, when shifts are cut and hard decisions are made, that it isn't viewed as a commentary on value, but you know, unfortunately, we are pushed into a situation sometimes where there's just no good solution, where the answer is unfortunately just very hard. Now, that said, you know, I know at our institution, we've worked very closely with the residency in making all of our staffing changes to try to find ways to, you know, make sure we're still providing opportunities for our residents, especially to be able to participate in care and get the variety of educational experiences that they want. We're trying to find ways to involve them in telemedicine. We're trying to find, you know, along with the education team, you know, ways for them to maybe even participate virtually in the care of some patients when they can't be in the room. So, you know, I think especially right now, you know, we're just coming out of probably this first COVID hit where everyone's a little bit shell shocked. And I think finally now probably we're going to have some brain space to try to think about, you know, how can we rebuild educational opportunities and really help our medical students and residents, you know, get the experiences that they need. And I think over the next few weeks and months is where you're going to see those new programs and initiatives really come into play.
Thank you. I would just ask you sort of similarly, Dr. Holmes, we've seen a similar effect in research where some people have really noted that those that have really put a lot of work into some of these ongoing projects now seem to kind of have been leapfrogged for things that are COVID related. What advice would you have about making the most of this experience and also using it as a sort of a learning opportunity to make sure that you have planned out a research career in a way that you can navigate uncertain things like this?
Well, I think the first thing to do is decide if you want to study COVID. So if you have any desire whatsoever to study COVID, the time is now, because institutions, especially the NIH, has thrown a lot of money at COVID, and you know, foundations as well. SAEM Foundation now has a grant RFA out for COVID-related research. So if you're interested in studying COVID, the time is now. It's your lucky day. Get ready, get going. In fact, while we're sitting here, I just got a IRB approval for a COVID study that I'm going to do, that I mentioned that we're going to do with one of the residents here. So if you're interested in that, you know, this is the time. And even if you're not that interested in COVID, in fact, to be honest, I don't have any interest in COVID at all. In fact, I'd like for COVID to go away. But you know, I thought this would be a great project. A resident came up to me and said, do you have anything on COVID you'd like to do? Because I'm interested in infectious disease. And so we worked out this particular project. So that's there. Now, if you're embarking on a research career and you have other things going that aren't COVID related that maybe are on hold, the time is to be patient. The time is to do other things related to that project now. So for instance, we put one of our prospective studies on hold, and I'm now spending the time that I would have spent in the daily kind of operations of the study, but writing the manuscript. So there are other opportunities that you can do now to make up for the time that is lost because of COVID.
Thank you. We've got another question from Sarah Kleinschmidt. She says, any brainstorms, and we'll direct this one to you, Dr. Lahl. And then Dr. Rivera, if you want to also address this from the department perspective, any brainstorms or thoughts on how to replace SIM and procedural education while distancing is still in place? Is online SIM even worth the time? Does this open up opportunities for asynchronous experiential learning? So we'll take the learning and education perspective from you, Dr. Lahl, and then Dr. Rivera, if you want to talk more about things that departments can do more from a distance, that'd be great.
Sure. So I think, this is the time really for probably low fidelity simulation to shine. And if you aren't familiar with that term, it's basically simulation that does not involve a simulation mannequin. So, we have an attending that always makes a really great chest wall for practicing thoracotomies, chest tube insertions, and other things using a rack of ribs. So now is the time to do things that can be done, one-on-one with a learner or in a very small group while still employing distancing. We have some other models that we use for central line insertion, looking for ruptured globe that are also low fidelity. So I think, this is the time to really be utilizing those resources. In terms of online simulation education, full disclosure, I don't know much about that. But in my opinion, the heart of simulation comes with the hands-on ability, and I'm not quite sure how much of that can be achieved through an online platform.
And just to chime in a little bit about kind of in the clinical environment, some of the teaching opportunities that maybe are enabled a little bit by some of the COVID era. So, I was really, I witnessed something a couple weeks ago where we had somebody gowned up in PPE putting in a central line on a suspected COVID patient, and they were broadcasting what they were doing via telemedicine. And so we were able to have an attending and a trainee in the room talking through a procedure, and other trainees, and actually in this instance are one of our ICU providers too, where they're watching via telemedicine and teaching and talking. And I thought, well, this is really interesting actually, because with this technology now in place, this is far more people that get to benefit from witnessing and discussing this procedure than we ever would have seen prior to COVID. And so I think that's the kind of thing that we can do going forward, even though we have lower volume, even though there probably are on the net fewer procedures happening. If we can utilize some of this technology to be able to bring that learning to more people, then we can still keep up those learning opportunities.
And then I would follow up with that and say, I think that makes perfect sense, and that's great insight. I would imagine that Stanford is a resource-rich environment. How would you recommend folks go about doing that if they may not have as many resources at their disposal? I mean, I guess what would sort of be the basic fundamental steps of the approach to get something like that started?
Yeah, well, so, I like to say that the simplest version of telemedicine is a walkie-talkie and a window, right? You don't need a fancy mounted widescreen camera to be able to participate remotely. And, I think the same thing that I just described could have taken place if people were cognizant about it, with a bunch of trainees kind of gathered around safely, the room, looking through the glass door with the ICU attending, talking them through with some communication method that allowed the team inside to be able to describe what they were doing. I think the key to what I observed, even though the technology enables it, I think the real key was just being cognizant of the fact that some of these learning opportunities are reduced, and when we see them, we need to maximize them.
That's a good point. Thank you. We have another question from Nacha Romani-Thorn. And Dr. Bird, we'll direct this one to you, but really I think it's a good question for all the panelists, because ultimately we know that it's really important to have a mentor and to have sponsorship and things like that in academic medicine in particular. So we'll specifically, Natcha asks, Dr. Bird, would you be able to advise on visa sponsorship for international medical graduates applying for EM residency this cycle? Would this be affected due to the financial crisis that hospitals are facing currently?
Yeah, that's an interesting question. I think it largely depends. I mean, well, let me back up. The cost of visas within a GME office is minuscule compared to the budget of a medical school, right? So, so I don't think, my personal opinion, that the budget will necessarily be part of it. But I do wonder, will residencies contract, for instance? And if that's the case, then they will need to interview less people. So that's a potential. I also, some medical centers have a tremendous amount of trainees that have visas, right? So that's kind of like their lifeblood. They do this all the time. Well, unless they're going to completely turn off the spigot for their workforce, for their trainees, which they're not going to do probably, then it won't be affected. If it's an institution that has very few trainees on visas, maybe, everyone is working so hard, and in different areas that I could foresee a place that does this infrequently, that they may say, you know what, we just don't have the bandwidth to do this. And so they wouldn't pursue it. That's my best guess.
Thank you. We'll say next, specifically talking about mentorship and thinking about the value of having a mentor. Dr. Holmes, I know that this is really critical in a research career, and getting involved with someone that can guide you through and help you navigate research early on is really important. What opportunities do you think have come from COVID, and what advice would you have for really trying to find a mentor early in this time? We'll just have to unmute you real quick.
Sorry, thank you very much. It's a very interesting question. And I mentioned yesterday in my president's speech that potentially mentorship's the most important thing in academic emergency medicine, especially research. And I've been fortunate with great mentorship over my career. In the current environment, it's going to put some challenges on mentorship simply because day-to-day interactions are changed, right? You can't stop by your mentor's office and talk to them for a while about what they should do, what you should do next, that sort of thing. It's changed to electronic communication, phone calls, Zoom, those sort of things, which are still sufficient. We have scholars at our institution who one of their mentors may be at a different hospital just because of a unique skill, and they meet via Zoom, and that is successful. It's just not quite what meeting in person, going to a coffee shop, something like that can be for that mentor-mentee relationship. So there's definitely going to be some challenges that are going to have to be worked out while we are distanced with COVID.
And do you think that having, especially because regional and national meetings were such an opportunity to identify mentorship and collaborators, do you see anything taking the place of that?
Off the top of my head, no. I think it's going to be trying to network with other students and other residents to find faculty at other sites to help you find a mentor that's potentially can sponsor you with a project. And it's going to take a little bit of trial and error to find that right person.
Okay. Dr. Rivera, let's kind of pivot to you and say, so operations is something that really is learned through experience. And having mentorship in that will obviously help a lot. How would a resident or a medical student who thinks, yeah, I'm interested in actually what does it take to run an emergency department, develop the protocols and do these things, what would you advise them to do as far as gaining experience and finding someone that can mentor them in that process?
Mm-hmm. Yeah, so I mean, I would say this is, if you are interested in operations, this is a fantastic time to kind of jump in and try to get a peek, because this is not something obviously that happens very frequently, and the challenges that are being faced and overcome by operations teams across the country right now are kind of perhaps hopefully once in a lifetime. And you know, I think a lot of hospital operations as well is something that you can learn very much by really just kind of experience. And these are fortunately not things that these are the experiences that you need to garner are things that right now are taking place in Zoom meetings, right? That's where the action is when it comes to hospital operations. And so I would imagine, I know certainly this is true for our team, and would probably be true at hospitals across the country, that if you were to reach out to whoever is managing your local operations and said, hey, you know, can we chat about this a little bit? Can I hang out in some of your meetings? I mean, sometimes some sensitive decisions are being made now, and so that you might not be able to be privy to all of it. But I'm sure there would be opportunities to just listen in, and there is so much learning that could happen from hearing hospital administrative teams and ED operations teams talk through the challenges that they're facing now and the various solutions.
Great, thank you. Dr. Law, we have another question that I think would be perfect for you from Stephen Olivoy, who says, with low patient volumes, do you worry more about the junior learners than those near graduation, and any differential solutions?
Yeah, so in our shop, we actually pulled all of our interns off non-critical rotations. And this happened for our second and third years as well, but we changed our staffing model so that our residents are working a reduced number of shifts in the emergency department, but they are working more months now in the emergency department. So basically, starting in March, when the medical students were pulled, our residents who were doing ultrasound, EMS, observation medicine, toxicology, our education rotation, admin rotation, they all got pulled and brought back into the emergency department. So I think it's actually probably given our interns a bit of a leg up, to be frank, because now instead of having 6 emergency medicine months between peds and adults in their intern year, now some of them will have 7 or 8. So I think they're going to actually kind of be ahead of the game. I don't worry much about my graduating seniors. I think they were, if push had come to shove, they were ready probably when this all started. I probably worry right now most about my second year residents. In a 3-year residency program, the second year is really the mountain to climb. And I do worry a little bit for them about how long this lasts and how it will impact their training. So we are, you know, as I said, really working tirelessly to make sure that we have adequate opportunities for them. We think that some of our community sites may start to see a rise in volume before we see it at Grady. So we're looking at redeploying our residents and having them work more shifts in our community sites so they are still getting a lot of patient experience and patient encounters.
Thank you. I'd like to go back, Dr. Bird. We've all talked about, you know, doing a lot of different things. And I think that that's a theme for students, residents, and faculty members, that so often we try to push ourselves for productivity. And we've certainly seen lots of opportunities to be more productive with COVID. But what advice would you have about trying to balance your desire to stay productive and betting on your resilience with also being aware of the sort of inherent threats to your wellness and the stressors that are going to be associated with taking advantage of those opportunities to be productive?
Yeah, thank you for that question. So what we've seen in New York and here in Massachusetts, where right now our ICU capacity is 150%. And I think we have something like 102 COVID patients on ventilators. What we've seen is that the people are doing okay people are not proactively reaching out for help. But once, at some point, the tipping point is going to be had, and people are going to be in a lot more distress. So, I think many places residents are working less hours or less shifts, which I think is probably protective, because for those who haven't really worked in it, I mean, it's mentally exhausting, right? You're in and out of PPE all day. There's just this, you're seeing everyone's eyes, and that's all interaction you have, and you're smelling your own bad breath in your N95 for 8 or 10 hours. So initially, and I think it was manifest in our engagement survey with the residents, that people are doing well and they've rallied, but the time is going to come when we're going to pay the price for that. So, what can you do? So I think working less hours, if possible, is probably protective, my opinion. Looking for ways to connect with friends and families via Zoom social hours, depending on what the social or distancing policies are in your state. That's protect, right? We know that people who have someone close to them, people they care about, right? That's protective of distress. So somehow can you do that, right? I worry about the residents who are, right, they're from some other part of the country, they're here by themselves, or maybe with a significant other, and that's really it. And they've, like, to a large degree, rely on their cohort of residents for some of that support. And right now you can't get it because you're not getting it on your Wednesday, your conference day, and you're not getting it after a shift, or you're not getting breakfast after an overnight. So, whatever means you have of maintaining some social connection, I think is critically important. You also have to, take care of yourself physically as well, right? So it's trying to avoid putting on the COVID-19, but maintaining some healthy habits, because we also know that is protective against distress. So, right. So Downward Dog Yoga is free online. Orange Theory Fitness has free right? There's tons of that kind of stuff. But again, it is kind of hard to do it by yourself in your apartment. So one thing that we did at UMass was, and I know we were the only medical school in New England and maybe in the country, is that we offered the fourth year medical students a chance to graduate early. And every single one of them took that opportunity. And and then offered them, if you want to graduate early, we will get you an emergency 90-day license in Massachusetts, and you can work in our field hospital. So our arena in Worcester has been created into a 220-bed COVID hospital. And so, I don't know, 40% of the medical students said, yep, I'm starting work. So, and that has been there was just a thing published in the paper about it. So a great experience for them. So somehow finding people that you can connect on an emotional level in real time, which is more difficult, or virtually, I think is important.
Obviously, we're trying to do that to some extent here, given opportunities to connect with you and receive your guys' expertise, which we appreciate. We're getting low on time, and I would like to ask a question that for everybody to answer. I would like to say, when we came up with the topics, it was tough to narrow down, but we ultimately landed on these 4 topics because we know that those are all pillars of what people will involve in their careers or build their careers on for academic emergency medicine, operations, research, education, and wellness. And so we wanted to give an opportunity to our members to hear about what it really requires to develop the opportunities to have expertise in those areas and ultimately pursue these careers. So my simple question would be, if a medical student or early resident comes to you and says, I love what you do, I love your job, what is it going to take for me to get your job? What would you tell them, and what advice would you have?
I can do it quickly and simply. you simply need to do a research fellowship. That's the first step. So if you're gonna, in the current era, to do kind of have a research type job where you're gonna do research as a career in addition to your clinical work, you need to take 2 years and do a research fellowship.
So once they're done with the fellowship, Dr. Holmes, what about from there? Because many really are not sure yet, even if they want to do a fellowship. How would, if they're at an earlier stage, how would they know if they really want to do research and even go to do a fellowship?
Yeah, so if you're at an earlier stage, say you're a medical student or a first-year resident, and you have some interest in research, that's the time to get your feet wet, do some projects, spend the time, and decide if that is what the career that you want. So I would advise finding either projects that are ongoing that you can work with, or if you have an idea yourself, link up with a faculty that can help you grow that idea and get your feet wet, do it, and decide if you love it or hate it. Decide if you life without it, or you're like, oh my gosh, why did I even think about this potential career?
All right, we'll go next to you, Dr. Rivera. I'm a fourth-year medical student or a new intern. I say I want to live the dream like you're living the dream in ops. What do I need to do?
So this is actually in rather stark contrast to a research career, because I think, one of the things that's interesting about operations is every single emergency department in the country needs somebody to pay attention to operations. And so the demand is actually very high. I would say if you're interested in working in operations in the community, to be honest, most of what you need is enthusiasm, because so few people actually even enjoy this work. Like the average ED doc going to work in the community does not want to be involved in administration and operations. They are happy to let somebody else take care of it. And so very often, I mean, honestly, if you're going to the community and you're like, you know what, I want to start taking this on. I want to see how we can, increase or decrease our door to balloon times. I want to, start working on a sepsis protocol for our group. People are going to let you do it. And so it really is just kind of about enthusiasm and hard work and just being interested in it. Now, of course, if you want to work in an academic center, if you want to be someone who's kind of innovating around operations, who's writing papers on operations, then definitely an administrative fellowship is very helpful. I don't think it's the only way to get there, but they are increasingly available across the country. More and more programs are offering them. And, I think even if you have a background in business through your undergraduate or graduate degrees, administrative fellowships are a great way to really get a lot of hands-on experience with ED operations specifically, and to learn how some of those kind of basic finance and accounting or operations principles apply to ED environments. And, there's a wide variety of them out there. Some of them get you degrees associated with them. Some of them are only 1 year. And so I would certainly encourage people, if what you want to do is publish around it, innovate around it, or work at an academic hospital in operations, then definitely a fellowship's the way to go.
Great, thank you. Dr. Bird, we'll go to you. What does it take to really be a champion for wellness and to build a career in that?
Yeah, first of all, I thought for Dr. Rivera, when he said, if a student says, I want your job, he would probably say right now, take it.
Yeah, definitely.
So listen, I stumbled into my job. There are very few wellness officers. I had NIH funded research. I did that for 12 years. I was residency director, and I proposed actually a chief wellness officer job at UMass about 3 years ago. And keep in mind, there were 0 academic medical centers with a chief wellness officer. So not surprisingly, it wasn't accepted. So, I think there are, and the other difference I will say in medicine versus industry. So industry has had wellness officers for longer than academic medical centers, but the role for wellness officers in industry is to drive their own healthcare costs down, right? It's not about eliminating burnout and letting people thrive and be well. It's decreasing their costs, which is not the role of a chief wellness officer in an academic medical center. So I want to make sure that's clear. Honestly, how I got this was by saying, this is what you need. They said, no, see, this is what you need. No. And then eventually there was enough of a underground groundswell where they said, you know what, I think we need this. I think I don't have a crystal ball. I love what I do. And I hope I finish my career doing this. I don't know if this will ultimately be wellness officers, chief wellness officer will be instituted by all or most academic medical centers. I hope so, because I think it's clear that there's a need. You don't need a fellowship for chief wellness officer, that's for sure. I think knowing the people that I know in the CWO roles, they've all kind of fell into it because it's largely a self-passion of their own, likely starting from within themselves and wanting to be well and recognizing a need within healthcare.
Thank you. And our last comments we'll take from Dr. Lal, who we started with, and say, when someone comes to you and says, I want to be in education and do it as well as you do it, what do you tell them?
So, I mean, I think like the other speakers have already said, you have to have enthusiasm and passion. It has to be what you really want to do. I do always caution people that being a program director, clerkship director is far more administrative than it is educating. So, it's really about taking a deep look at yourself and thinking what brings you the most joy. If bringing you the most joy was when you were the fourth year medical student on the rotation and you were the sub-I, being able to help those third years navigate the system and teach them things and seeing that light bulb moment when they got it, then maybe you don't want to be an administrative educator. Maybe you just want to be an amazing bedside educator. And we need those clinicians everywhere. I think certainly residency leadership has a lot of reward, but there's also a lot of administrative duties and following up with people and ensuring that people get things done. But I think there's always opportunity for junior faculty in an academic medical center to get experience very quickly. There are always didactics to be given. There are always people needed to help for simulation. There's always people needed to help for oral boards cases, to help with a procedure lab for MS2s. So there's a lot of opportunity. And I think, early in your career, a lot of it is about saying yes and figuring out which opportunities gave you the most joy and maybe which ones you accelerated or excelled in the most, and saying, okay, now I need to look at that person again and kind of redefine my path. I think the other thing I'd say is that it's okay for the path to change, for the path to wander and meander. As long as you love what you're doing, that comes through. And I think that's what matters most in role modeling.
All right, well, that is the last question that we have time for today. Thank you again to everyone for joining us tonight, and to the rest of tonight's speakers for sharing your incredible insights and for helping residents and medical students navigate the COVID crisis a little bit better at our own institutions. Keep a lookout for more materials from RAMS in the coming months. Stay safe and have a good night.
Thank you, everyone. Be well.
Good night, everybody. Thank you, Dr. Starnes.
Thanks so much.